So this next section that we're going to have came about in that as part of my efforts, I speak around the country at different programs and also have visited with a variety of organizations and employers who are constantly looking for guidelines on how they can improve what they're trying to do, what direction they should take. And over the last few years, there's been a growth of programs that offer an employer the ability to have guidelines, directions, standards, as metrics, et cetera, to use to either be accredited or recognized. There's at least 5 or 6 organizations I'm aware of, and we have the 3 leading ones here today with us. The Accreditation Association for Ambulatory Healthcare, the National Committee for Quality Assurance, and the Joint Commission. Other groups that are engaged in this are URAC, the Patient Care Collaborative, and there may be some other groups I'm not even aware of. But what we want to take this time in this hour is to have you hear a little bit from each of these groups, from a representative of the organization on what their organization's value equation is, and then have one of the clients, one of the employers or vendors who have decided to become accredited or recognized through this group, and explain why they went about doing this. And so what I'd like to do at this point is to introduce all of them all at once, and then we're going to have them speak from the tables there, and then we'll have an interaction. Again, the title of this is What's the Value of Accreditation? And we want you to learn about it. So from your right to left with me is Jackie Hope, Director of Quality Compliance and Privacy Officer for AAAHC. She actually works for CARE ATC, which is an on-site clinic vendor. She's been a registered nurse for over 25 years and has worked in the quality and regulatory arena in her nursing career. But she also serves as a surveyor for AAAHC, and in her 20 years of serving organizations throughout the U.S., she's got tremendous experience there. Next to her is, yes, Lisa is next to her, thank you. Lisa Mueller is Doctor of Physical Therapy. She's with Quad Med, joined at 2012 as a staff physical therapist, and she leads their physical rehabilitation department as a supervisor. She's also been involved in project manager, which brings her to her current role as continuous improvement leader. And she's responsible for all strategic advancement, process improvement, and accreditation efforts, and is a client of AAAHC. Next to her, Michael Kloszewski. Close enough, Michael?
Close enough, Larry.
Okay. Michael's the Executive Director for Ambulatory Healthcare Accreditation at the Joint Commission. In his role since 2010, he directs business development, strategic direction, overall product line management for the Ambulatory Care Accreditation Program. The program covers over 2,100 accredited organizations nationwide. They provide, starting in 2015, the Joint Commission provides a guide to applicability of ambulatory care standards for worksite programs. Next to Michael is Michelle Smith-Jeffrey, Dr. Michelle Smith-Jeffrey. She's Acting Director of the Federal Occupational Health, a client of the Joint Commission. Prior to her role, she served as the Federal Occupational Health Medical Director and has over 25 years of extensive internal and occupational medical experience. For approximately 13 years, she was medical director at the Police and Fire Clinic and Occupational Medical Clinic in D.C., providing comprehensive occupational medical services. Next to Michelle is Alan Sturkoff, Dr. Alan Sturkoff, Senior Medical Director at Cigna, a clinical leader of Cigna On-Site Health, a client-based clinical delivery strategy, and he oversees all of Cigna's clinics for their own employees. His career focus has changed on-site health, and he's helped open on-site clinics for Johnson & Johnson as well as CHD Meridian, and he is a client of the NCQA. And finally, Ches Gwynn is Director of Employer Relations at the National Committee for Quality Assurance, and in his capacity is responsible for representing employer needs for NCQA. So let's start out with Jackie, and I'll give you a control here. And my phone's right in front, so don't put paper over it. Okay.
Okay, as he said, I have been a surveyor for HHC for 20 years now. I got into it whenever I got my first organization accredited. I went to a conference actually in San Antonio and was approached by the staff. I love doing it. I do it. We have a certain number that we have to do each year as far as surveys, but I love getting out in the various arenas of healthcare and actually working with the different organizations to accredit them. HHC was created for ambulatory care by ambulatory care. It's recognized by regulators, health plans, insurance companies, and virtually all other stakeholders. They have over 35 years dedicated to quality improvement in ambulatory care, and the surveyors are experts practicing health professionals. The accreditation process is a true form of peer review. I actually just got my organization, my third organization accredited under this network accreditation that I'm going to talk about a little bit. And we are in 17 states and have 57 clinics. So it's actually all peer-based, and physicians come in, nurses, administrators, and they actually go through the chapters and review everything. So it's actually peers that work in the profession surveying. The philosophy is consultative, collaborative, and there's a discovery period. So you look at the organization's policies and procedures, you look at all those different ways that they're meeting the standards, and work together as a team to show how they meet those standards. The network accreditation that I mentioned is for organizations that provide healthcare services through a network of a minimum of 10 healthcare sites for contracted parties, patient populations, or the general public. Small primary care clinics are included in this. I'm getting behind on my slides. Okay. The primary care clinics are employer-based, occupational clinics, retail clinics, urgent care, on-site, near-site clinics. The organization I come from actually has on-site and near-site clinics as both. The value of HHC accreditation is recognition from consumers, payers, employees, and then it gives you a competitive edge in the marketplace. Thank you. It helps with risk management and risk reduction, and it improves business operations. Okay, more value, medical home accreditation and certification for eligible organizations. We actually had that standard apply as well for my organization, and it's a new wave. It's a way of providing health care, and it's an awesome process to go through. They actually customize the survey process, and it's flexible and adaptable to meet the needs of your organization. It's consultative and educational, and you get a certification for each of your clinic sites. We do have HHC staff here today. You guys can raise your hands. So be here to answer any questions you may have, and I'll be here as well. I'm going to pass it over to Lisa.
It's the same presentation.
Yeah, I don't have any slides.
Yes, that's what I thought. Okay. Janet kept looking up, and I just didn't know what to think there. Okay. Sure, go ahead.
Okay, so I don't have any slides. I read the Steve Jobs book that said no slides is the way to go, so here I am. So I can just speak a little bit about QuadMed's experience in working with HHC. So we started our journey with HHC much before I was a part of the team. In late 2012 was when we had an accreditation team really formed to start looking at who we wanted to partner with, what that process would look like, the resources we needed. I at that point was not really involved. My involvement came in about a year and a half ago when our prep work for being accredited really started to take flight, and I stepped in as a project manager. So I've been working with HHC for about 18 months now. We received our our certificate for network accreditation in September of last year, which means that we've got about 30 sites that are accredited under a network certificate, and had about 10 of those sample-sized surveys completed on site to kind of represent the whole of the network. And since that time, we've had a couple compliance surveys in the last year as well. I can only say good things about the experience that we've had, just the collaboration that we've received from AAAHC, the credibility I think it restored in us as a healthcare provider to have that level of expertise and the quality we provide to our patients. I could go on and on and on about all the things that we've really just benefited from being accredited by AAAHC.
The one thing I'd add is going through the process just makes you so much better. Mm-hmm. And like she said, it's not something you do overnight. It actually is a process. And I took 3 years to get my company where it needs to be, but it's a wonderful process to go through.
Great. Michael?
Okay, Michael Kolzicki, Executive Director of our Ambulatory Care Accreditation Program at the Joint Commission. I've been there for almost 14 years. And you should actually know Larry Boris has quite a voice at the Joint Commission. In his role as leader of Midwest Business Group on Health, he served for many years as an advisor on our Business Advisory Group. Now, Larry and I share the same vintage, and you could tell because on the agenda it listed my name with JCAH. We haven't used that name in 20 years, Larry. Since you did not. So 30 years ago, we were JCAH. We accredited hospitals. We've actually been accrediting in the ambulatory environment for 40 years. This is our 40th year recognition. But we did convert to Joint Commission 8 years ago, Larry. Okay, so I'm going to say a few brief words about our model, but mostly I want you to hear from Michelle and her experience and tell the federal occupational health story. So we view accreditation as a partnership. You've, in the cases entirely with Worksite Health, you voluntarily invited us in as a third-party evaluator, a set of eyes and ears, because you can't be on the ground from the central corporate office at all your sites spread either regionally or nationally. The components of our partnership is compliance with a subset of our ambulatory care standards. As Larry mentioned, we work with the occupational health field to whittle down the complete set of standards to those applicable for worksite, near-site occupational health settings. And we help you, we partner with you to be always compliant. You're not preparing for the next survey. Hopefully you're preparing for the next patient you see that day and the next day. So that partnership exists of an on-site survey like AAAHC every 3 years, but we also add a inter-cycle self-assessment done electronically. So in year 1 after survey experience, in year 2, you're telling us we're still in compliance or we've lost a staff member, maybe we didn't update our policies, we need to refresh in that area. And the other important thing is our process focuses on ensuring not only patient safety, but also worker safety. A colleague and I presented a month ago in San Francisco at the AOHP meeting, and it was really built around non-accreditation research work the Joint Commission has done about worker safety issues, like respiratory protection. The value equation, much the same as AAAHC, it gives you credibility in the local community for the workers you're trying to attract and have that high penetration rate for the families that you may serve if you so use that model for your referral sources. We found for many of our customers that use Joint Commission ambulatory accreditation in a competitive healthcare marketplace, scarce resources for nurses, physician assistants, advanced practice nurses, accreditation aids in recruitment and retention. And we've heard that very clearly from our customers. We have a systems process for large regional and national firms, and that process is designed not only to examine the care as it's being delivered at each site, but also to look at your organization as an overall system. and the things you do at the corporate level, and you expect that they're taking place every day at the site, this gives you the opportunity to really measure whether that's happening. And the Joint Commission is recognized for over 60 years now for awarding the gold seal of approval. I would also mention lots of discussion this morning about one variety of your models is to develop the care you provide as a primary care medical home. We have the capability to add a primary care medical home certification on top of your accreditation from the Joint Commission. A lot of myths about the Joint Commission. I was at a show with Kristen, my team member here, earlier this week, Medical Group Management Association. As I said earlier, 40 years that we've been doing this. We still have people coming up saying, geez, I didn't know Joint Commission worked in the ambulatory environment. But we do, and our surveyors only evaluate ambulatory organizations. So we have a unique set of surveyors that are trained on the ambulatory settings, ambulatory standards, and the survey process. And also a myth that we don't understand worksite health. For many years now, we've had existing relationships both with ACOEM and Urgent Care Association of America, and the last couple of years with NAWHC. And we accredit a wide range of what we call episodic providers in terms of occupational and worksite health, urgent care, and retail clinics. This slide just illustrates the suite of services, all complimentary, that you receive from the Joint Commission. But most importantly, I wanted to turn it over to Michelle and let her tell her story. So.
Good afternoon. I'm going to start by telling a little bit about federal occupational health, because I think most people don't know much about federal occupational health. We were established by congressional mandate in 1946 to improve the health, safety, and productivity of federal employees. We currently serve 1.8 million employees at 360 customer agencies at 406 sites across the country. These 6 sites include fitness centers, and of that 400 sites, 369 are clinics. So why we chose to become accredited by the Joint Commission was a decision that I wasn't involved in. That preceded me just by a bit, but one of the reasons that we chose to become accredited was that we wanted to exceed expectations. As I mentioned before, we're mandated to provide the care that we provide, so it wasn't necessary for us to become accredited, but we chose to become accredited because we felt that we would improve the quality and safety across the services that we provided. The second thing was that we wanted to invest in FOH's future. One of the visions for FOH is that we would be the healthcare provider of choice in the federal government, and we felt that by becoming accredited, that would provide us an opportunity to improve the quality of our care that we provided and give an emphasis on safety that hadn't previously been part of the culture of federal occupational health. We also thought that we would have this would benefit our customers by choosing industry-leading standard for quality as a framework. We could build an infrastructure on which we could grow, and that would become a solid base for our growth. We chose the Joint Commission to do our survey because the Joint Commission had the ability to perform a system survey. And so we provide care across 4 service lines: behavioral health services, wellness and health promotion services, clinical health services, and environmental health services. And the Joint Commission could survey all of our services and provide accreditation for all of the various services. The other thing was that the Joint Commission was able to survey a large number of our clinics and our fitness centers. The Joint Commission surveyed 109 centers in 3 weeks, over a 3-week period, across the United States, in 13 states and in the District of Columbia. So our roadmap to becoming accredited, our journey began in the spring of 2014, and we did a quick assessment, and not so quick, it actually took us a while to assess all those centers, but we found that in 23% of our sites, practices aligned with the Joint Commission standards. In 25% of our sites, the practices partially aligned with Joint Commission standards. So we knew that we had a lot of work to do. We did some strategic planning. We hired a group called our OPAC, which is our Office of Policy and Quality, and the OPAC was about 7 members who were devoted to writing and preparing us for the Joint Commission and doing the strategic planning. We then had to implement what we knew were our deficits and make changes so that we could address those deficits. And we were struck by 2 things during that process as we did our implementation with the Joint Commission. One was that the Joint Commission had resources that were really helpful in terms of us getting to our goal of becoming accredited. The standards, the Joint Commission Standards Interpretation Group was always available for us to ask questions as a resource, and so they were very helpful in the OPAC planning, how to proceed and implement changes. We also used the Leading Practices Library. There were a lot of forms and that we needed to develop, and we were able to use that as a resource as we move forward. One thing that we noticed was that communication was a huge problem for us because we have so many sites across the country. And so we developed, I gave this handout, we developed a microsite called Go University, and that was a resource for all of our employees to get information about our preparation for the Joint Commission. We then pre-tested by surveying our own sites, and then finally it was time for us to be surveyed, and we were just surveyed this summer, late this summer, by the Joint Commission. The sites were actually requesting the Joint Commission surveyors to come after the process started because the word got out that the Joint Commission surveyors were supportive and consultative and worked collaboratively to improve services in the clinics. So we had expected and unexpected outcomes, and that's the OPAC team with a couple of the surveyors. We expected that going through this process would unify the staff at Federal Occupational Health, and it really did. It brought people together around a common goal. We expected that we would improve our culture of safety and quality, and that occurred. In terms of benefits to customers, we felt that we would have an industry-tested standard that we had implemented, and that occurred as well. And then we were looking to standardize systems and streamline processes to save, to realize a cost savings across our organization, and that happened as well. But I think probably the most surprising thing to us were our unexpected outcomes, and one of those was that we developed a common language so that across the services, the various services, as an organization we spoke a common language, whereas before the services were fractured, each doing their own thing and coming together only occasionally. We had a new dialogue across Federal Occupational Health, the commitment to quality and safety. All of our discussions focused around quality and safety, and when we were implementing new processes, the focus was really on quality and safety where it should have been. We also had the level of unity was a surprise to us because we didn't expect to have the organization come together as much as it did from going through the process. We also had a high impact systems change, and this gave us a pathway and leverage to sustain the gains that we had made going through the process of becoming accredited. And finally, our partnership with the Joint Commission was, I guess, a real surprise to us. Most of our staff had heard about the old the JCO survey, and so everybody was very fearful when we started the process. And I on the other side of the handout are some of the myths and facts about the Joint Commission, and these were myths that we heard as we started the process and were able to dispel. So overall, we had a really great time and journey going through our journey to become accredited. We found that the surveyors really did work to educate and empower our staff, and now we have staff really involved in providing quality care services, looking at risk issues and managing risks. And so overall, we had a very, very good experience. I do want to mention that we had a lot of questions from the staff about why we had to go through the accreditation process. Why couldn't we just do the standards on our own and then not bother going through the formal accreditation process? And I would say that it was a great benefit to us to go through the formal accreditation process because we were able to use all of the resources of the Joint Commission and not just leave the implementation of the standards to our own interpretation.
Great, thank you. Now let me turn it over to Chess, and pull that up in a minute.
See if we get to this slide. I'm not going to play with it till you finish. So okay, terrific. Well, good afternoon. Frankly speaking, all three of us have strengths in our programs. And as a former benefit manager of a large U.S. bank for about 15 years, I kind of will always refer to myself as an employer, put myself in your shoes. And depending upon where each of us are, do it again, in our journey of the continuum of how we're going to provide and set up and what model we're going to implement, you may find strengths in any of the three of us or others. The main reason we point that out is that based on our culture, our individual objectives and goals in our organization, the type of model that we have, all of these programs are available and have various strengths from which to pull from to realize all the objectives and the return on the ROI that we'll all be mentioning. Let me give you a minute about the philosophy and the building blocks of the program before Alan describes how Cigna is using this program. We're relatively new to this process. NCQA has been around 25 years, as you know, and has all types of accreditation programs. But building upon PCMH and some others that were mentioned, we started stepping back a little bit when folks said, well, if you've been doing all these other things 25 years, why aren't you more involved, especially in the worksite setting? So we stepped back and looked at the current landscape. And what we basically saw was three things occurring. Clearly, the payers, health plans are moving more towards fee-for-service and paying for value. And to us, part of value is effectiveness, and how you, in part, achieve that effectiveness is coordination of care. But also, now the public policy is moving that way as well, and you've all heard HHS and their plans for changing Medicare reimbursement. And again, in large part, many of those components are based on, again, coordination of care. And of course, as consumers, we're all going to, or most of our employees and the general public consumers are taking care of more and more, going to more and more alternative care settings. So as a result of that, there's a multitude of these various, from retail clinics, urgent care centers, our employer sites, of course, and many others. But what we saw in order to achieve that higher effectiveness, the value base that the payers are beginning to pay for more and more, is the medical home as a central force. If we look what many of us employers over the years have been critical of patient-centered medical home, thinking maybe it hasn't produced ROI or enough empirical data to justify it, but more recently, over the last couple of years, especially when applied to chronic illnesses, clearly there's a stronger return there. But even organizations such as the ACOECM clearly have made more recent statements about in order for us all to go together, all segments of the healthcare world need to be coordinating care as employees and consumers go to those various alternative delivery sites, and the sharing of information, coordination of teamwork becomes more and more critical. And they themselves are even pointing that out as you see there in that quotation. The medical home neighborhood, again, you see why that becomes a foundation philosophically and as well as a building block for our what we call patient-centered connected care is our ambulatory care program. But our experience in starting with PCMH over a decade ago, more recently building on that experience again, being very, again, patient-centered with our new specialty practice recognition program, and even more recently with the ACOs. What they all have in common is being patient-centered and being connected and sharing information and coordination of care. So if we look at what is the patient-centered connected care program, it's probably easier to say, well, what does it look like by those recognized sites who have gone through the program? We have about 33 early adopters is our terminology that are now going through the program. You'll hear from Cigna in just a moment about that. And what we believe we're already seeing, and the program was designed to see them, is clearly to demonstrate that they are ready to be effective partners within the community, the broader medical neighborhood, and referring their employees to those patient-centered, the PCPs, and also sharing the information, what is learned, and vice versa, and not be competitors with them. And as you can read on through there, clearly the connecting the patients with the right resources at the right time is all part of the design that we have, because we're looking to the future. We're looking at how the marketplace is changing, how new alternative models will continue to be developed, and trying to outline a program for us as employers to either use in managing our own on-site clinics and or in choosing vendors and client managers for us who are certified. And clearly, these are the standards. There's a great, on our website, we get into infinite detail about these, but clearly in order to achieve those attributes that we just described, we have set these standards up. They're fairly flexible. We're early on in the first couple of years because we want to be able to adjust it periodically as the market changes, and we gain experience from our early adopters. And the goals, clearly that I think, there we go. All right. I'm just going to do all of them here. Clearly, the goals in terms of better outcomes and happier patients and improved operations should pretty well speak for themselves. But in terms of the employer's value, just to reiterate what's already been said, we as employers can use a methodology like this or the others here on the table to improve our own operations, save cost, have happier, more productive employees, and let them know that we are going by a national standard and evolving to protect them. And then also, if we can also use this program, as I said, in selecting vendors who are contracting, but also you can pick out elements and build those into your performance agreements as well. So more importantly is to hear from Cigna. And Dr. Streikoff, why don't you tell us your experience so far?
Great, thank you. So I just wanted to tell you a little bit about Cigna Onsite Health. We are in a unique position in that we are an employer and we're an on-site health company. Cigna Onsite Health is an LLC under Cigna, and we manage the on-site health business for Cigna. But in addition, we have on-site clients that are around the country. These are usually Cigna clients, although we do say that we are health plan agnostic, and we do run clinics for some other other insurance companies. So we have about 50 clinics. Most of them are episodic care. The most common model is a nurse practitioner MA model. We do have 3 primary care sites. We also have sites that are coaching only, and we're across 21 states. So when I first got to Cigna, there was a lot of talk about getting some type of accreditation, some type of recognition for all the good work we do. We know a lot of our competitors are getting PCMH recognition or certification. We thought it would be good to help build our brand name, to build trust amongst our employees and our clients' employees. there's marketing, quality improvement. There's a lot of reasons to do it. And I kept hearing, well, we should get PCMH certification. And what I had to explain to people is people hear the term PCMH, but they don't really know often what PCMH is and what it entails. And for our business, what we do with nurse practitioner MA models, it wasn't appropriate to be a primary care medical home. We weren't even delivering primary care. We were delivering episodic care. And it wasn't our intention to convert that. So while we were exploring different options, we learned about this new offering from NCQA, which was the Patient-Centered Connected Care model. And we saw that it was really geared towards retail clinics and on-site clinics, and it recognized our role in the medical neighborhood. So we were very excited about that. We didn't have to try to fit the round peg in a square hole and go through things that weren't really what we were trying to achieve, but we found something that we thought really fit, met where we were at. So, so why we chose to be an early adopter. I mentioned some of this already. We view our role in the medical neighborhood as supplementing care and not competing with care, and there's a really good reason for that. Cigna has a high-value network. We partner with a lot of physicians in the community. We're not looking to compete with them necessarily. We want to work with them. And we do have some primary care sites where there's a need for that, but we thought that this would be a great way for us to demonstrate that we are partners and that we're going to share information and that we're not going to try to steal patients from the medical neighborhood, from the medical home. As I mentioned, there was very little interest in converting to something more. We are considering some primary care sites when there's a need, but that's the exception rather than the rule right now. And overall, we're looking to decrease fragmentation, and we want to increase communication. And we say that we do that. And we have our providers tell us that, yes, we're staying in touch with the primary care physician, but how do we know that they're really doing it unless we start measuring it and looking at it? And when we started looking at this program, we learned that there's room for improvement. Just because our providers are saying that they're faxing notes, I wanted to see proof of that. And we've worked out some ways where we can look into our medical record and look at logs to see if test results and exams and immunizations and all that are truly being shared. So what have we learned? I think we've learned a lot so far. We've learned that going through a program like this, or any of these programs, it drives improvement in clinical practice. We got to choose some HEDIS measures, very similar to PCMH certification as part of this. And just as an example, we quickly learned that our asthmatic patients weren't necessarily receiving pneumococcal vaccine, which was one of the things we decided to measure. So this gave us an opportunity to improve the practice and improve the outcomes for our patients. We learned that we could do more with our EMR, that there were some aspects of care coordination that our EMR didn't address. And we built some new screens into the EMR that were specific to communication and coordination, as well as tracking chronic conditions and some of the HEDIS measures. There just wasn't a good place to record this information, and I think a lot of EMRs out of the box don't do a great job with population health. But this gave us an opportunity to figure out where the gaps were and to try to fix them. The other thing that we learned, and we were happy to see this, we were a little concerned, our providers were very supportive of this initiative. I was afraid that they would feel that this was a burden, that on top of their busy daily schedule, now they had more things to document, more things to stay on top of. But medical professionals are interesting in that if you show them where they're at and they're not at 100%, it drives them. And we found a lot of them, even though they scored 90%, they wanted 100, and they wanted to know how they could do better. So that was I'm very happy about how competitive and enthusiastic they are, and how much they want to succeed. So the other thing I'll tell you is that, as many of you know, as much as you teach, as much as you audit, unless you take a deep dive into a certification like this, there's things that you're not aware of. There's inconsistencies in practice, whether we're talking about clinical evidence-based guidelines or just documentation standards. So going through this has opened my eyes and our organization's eyes into some things that were just different across all of our sites that we could probably bring together. So I mentioned already working with local PCPs, which is our aim. The evidence-based care, and health promotion that the HEDIS measures demonstrate, and part of this program we were able to select initially the 5 HEDIS measures that we wanted to focus on, which was nice. It allowed some flexibility. We're working collaboratively towards the triple aim, which I think everybody wants to achieve, and we're hoping to lower costs both for Cigna as an employer, our clients. We want to close gaps in care, which is one of the things we really try to focus on, being we have health plan data. We can see what's missing and try to work with the primary to fix those. And we want to reduce redundancy in care. If I'm giving a tetanus shot in my on-site, there's no point in the primaries doing that in their office. But if we don't communicate and know what each other have done, there's potential for redundancy. So sort of to wrap up how it differs from other programs. Well, as I mentioned, we really couldn't be a true primary care medical home and provide all the care coordination that's involved in our small clinics. So we found that this recognition fit what we were doing now without having to change very much. You know, it was nice to see recognition specifically for on-site and retail. You know, it was something that we felt that we were being recognized, and our role in this big picture was you know, being recognized, and we could participate in and demonstrate how good we are at it. So the last thing I wanted to mention, by the way, is that as much as I appreciate the Cubs T-shirt offer, my New York Mets are still alive and playing tonight, so I will wear your T-shirt if we lose. But
well, you're welcome to give it to somebody else. That's fine. Yeah. All right, this has been a great education. Now the board had been asked to endorse an accreditation group, and the board felt, as Chess had said earlier, there's something for everybody, and so we're not going to be taking a position one way or another. But let me say I do believe that there is truly value in having a standard to live up to and bring consistency. So let's get questions from those. But let me ask you, for those who have on-site centers, are any of you accredited or recognized with any of these groups now? Okay. Do we have, Margaret, do you have the microphone? Okay. Jamie, perhaps you'll tell us a little bit about how you came up with your decision or something about it. We'll get a microphone to you in a moment there. Jamie, raise your hand so that she can. Okay, great. Thank you. It'll be on. Just keep talking.
Now try.
There you go.
Yeah. So my name is Jamie Stalker. I'm a physician. I'm with Argonne National Laboratory. I run their health and employee wellness program. We are a Department of Energy contractor, so we're not covered under federal occupational health. Each contractor is at privilege to set up their own clinic. It's a regulatory requirement by the federal government, specifically regulations from the Department of Energy. And we've had occupational health clinics for, I would say, probably in excess of 40-some years in some format. Many of the programs have been expanding to include preventive care and wellness. So we were sort of a latecomer into the accreditation process. Department of Energy has a program of recognition within itself, but there was not very good oversight from Department of Energy with respect to this small area of occupational health or wellness clinics. And also, they didn't provide real guidelines. So, you know, we have a to-do list, but we have so much more that applies to outpatient clinics in general that were not covered under the Department of Energy standards. So a number of the other Department of Energy sites have chose to go with AAAHC. I don't know that anyone went with Joint Commission. I think that the fear of Joint Commission, because these clinics are typically very understaffed and extremely busy, was we were thinking about Joint Commission in the times when we had worked in the hospitals and had to go through Joint Commission. As Larry said, maybe we're back in history. We had a great track record when we benchmark and hearing good things about AAAHC working with the DOE complex and these different sites. So 3 years ago, we chose to go with AAAHC. We found it a very valuable process, and we were really happy with it. I mean, we are a fairly intensively quality assured risk managed facility, so probably that typical outpatient surgical clinic is way behind where we already were, but we learned a lot in the process, and there were a lot of things that we needed to do to become even better. So we did pass with flying colors, which was good, and now we are planning on recertifying next year as well. I will say some of the other, and I talked to HHC, some of the sites across the DOE complex are thinking about not recertifying, and they're looking again at doing internalized peer review. I think that's mainly related to funding cuts from the federal government. We tend to be the first programs that get cut at these national lab sites, and as a result, I think that it's a funding response versus something that they weren't happy with in particular. Great, thank you. And there's somebody else who had raised their hand. The person who has a clinic who's been accredited? Thought I saw, oh, in the back, please.
David Hines with the National Schools again. Yeah, we went through Joint Commission accreditation, and we even had the medical home accreditation. I just changed over vendors, so we'll have to go back through the medical home accreditation process again. But from an employer perspective and looking at our on-site medical clinics, to me it was just a statement of quality. I wanted to assure the folks that what they were receiving in our clinics was equal to or better than what they're receiving out there in the general public. So, and that was our whole thing. To me, it was a good practice, but it was also very much a marketing tool as well.
David, did you make a decision between the different entities, or how did you come up with your choice?
We went Joint Commission because we would have had to have, when we looked at between Joint Commission and NCQA at that time, the NCQA would have had us take a look at each one of our 5 different worksite clinic locations and accredit them individually, versus the Joint Commission, we basically could do all of them together in one bundle.
Mm-hmm. Okay. Anybody else in the audience? Okay, well, there was Jamie talked about the budgetary cost. Could you give us some idea of the cost of accreditation? Jess?
Ours is right at about $1,500 per site, and then that breaks down. If you have more than 25 sites, we work out something that's scalable at that point, and then there's some minor fees for the electronic survey processing. So that's how it's structured currently. And if, however, multiple clinics are in fact using the same processes and procedures, they can go under one application.
Michael, how about Joint Commission?
Joint Commission, if you have a single on-site clinic, the cost is approximately $10,000 over 3 years. We spread those fees across those 3 years. But for an organization like FOH and some of the other users of our systems process, the cost gets down to less than $500 per site.
So it's per
that's not how we bill it, but that's how the cost would average out when we
okay,
do
so
that.
it's not per clinic, it's per site that an employer would have?
No, they get billed at the corporate level.
At the corporate level.
But if you broke the cost to a per site amount, it would be well under $500.
Okay. Jackie for HHC?
Well, actually, it's based upon the scope of the survey, how many surveyors go, how big, how many lives you serve, how many clinics there are. I know that sounds horrible, but I can't remember. I'm going to have to defer to HHC on that.
Could you, let's get a microphone to you, Margaret, please.
I can recall from our survey, which was a network survey of about 30 sites through HHC, it was about $1,500 per site.
Per site, okay.
You're looking at about how Joint Commission bills pretty much. We don't do annual fees, so your fee is due at least 20 days before your survey happens, but we do look at the size and complexity of each organization, and we consider that more of a partnership and trying to figure out where your locations are, and then we arrive with the pricing for that. There's an application fee, but it's a flat fee of over $700 just for the completion of the application. And then we work with you to establish sampling of your sites. So depending on if you have one site or 20 sites, the price will vary from that, but our prices on average start from about $3,000 and they go up, so depending on how many sites you have.
Okay.
And feel free to reach out to me. I can provide you with a specific price. If you have your organization, I'll be more than happy to provide you with an actual pricing for your organization.
Okay. Okay. Questions from the audience? If not, let me ask you kind of a double question, and we'll start out with you, Michael. What's the profile of an employer that would best be suited for your type of accreditation? And then what's the most difficult part of accreditation for someone?
So we currently accredit employers. There's a NASA site with a single site, and we do that. And we have gone now all the way up to 400 sites. So we do the spectrum, whether it's worksite health clinics or other varieties of ambulatory deliverers. I think particularly for regional and national companies, the biggest challenge is the fear factor. Before Michelle was there, I was present in 2013 when the director of FOH stood up and said, I know many of you don't want to do this. We are going to do it. We're going to start now, start at this point, and by fall of 2015, we'll be accredited. So it's the fear factor, but often organizations underestimate their ability that they're already doing the right thing. Many of the standards, both for the Joint Commission and others, a lot of it is just providing health care in the right way. So a lot of it is just making sure that you are following, in many cases, the policies that you say you're doing. Joint Commission standards often take an approach, you decide what policies you want to set, and then we'll evaluate you against those policies. So it's often the fear factor, but they're often much more better prepared than they think. And thirdly, I would say, to Michelle's point, the Joint Commission has rich resources both on the web, behind our extranet, and our great quality staff that partner with you to help you succeed.
Great. And Chester, NCQA, your typical employer and the biggest challenge they face?
Among the 33 of the early adopters that we have now, about not quite half of them are employers. The other half are contractors, the Cignas, the other folks that with whom employers would contract to manage that. Their sites, the employees, we've heard some of the statistics that are uncommon to run from anywhere between 600-700 employees up to about 2,000. And most of the early adopters have at least from 5 to 15 sites. So.
And biggest challenge?
Biggest challenge is exactly the fear factor and the unknown. We can talk for hours about the stories, but once they get in, though, as Dr. Strykoff said, these clinicians want to do better, no matter where they sit on the scale, and being able to choose, as they do with them and with us, certain factors that help them achieve their particular goals. They say, oh my gosh, I thought we were already there. What do you mean I'm 5% below? And so it does start that a competition. So it's quickly overcome in our experience, because then it kind of takes on a life of its own.
Great. And Jackie?
I don't know the actual numbers of the different organizations. I know from my surveying experience, I go out and I do ASCs, I do medical group practices. It can be a solo position to a very large multi-site, clinic. Like network accreditation is newer to us, but anything with ambulatory surgery we accredit. They've also gotten into the hospital accreditation, but I'm not going to talk about that right now. The biggest challenge, I think, is basically what they've said is it's trying to figure out where you are in relation to those standards. And as they all said, many times you're already there. And it's just allowing somebody to come in and actually it's an opportunity for you to shine and show how well you do things, but you're scared to death that they're going to come in and find something wrong. And it's not like that at all. And I say that from being on both sides of the table. So it's a really good experience, and I think everybody should go through it. I can't imagine not being accredited because that's just the way that I do things, and I look for that whenever I go and have health care for myself or my family. So
that's great. Any other questions? If not, again, there's tremendous value in accreditation and recognition. We would encourage you to explore all the options. Let's thank our panel. Thank you.